drug resistance in bacterial populations, gram-negative shock in septicemia, and obscure sepsis. These are the topics to be covered during the next hour in a program devoted to managing the serious problem of sepsis in the surgical patient. On Audio Digest Surgery, Volume 16, Number 8, for the week of April 30th, 1969. Participants on this program, recorded at the recent American College of Surgeons sectional meeting in Boston, include Harvard Medical School's John F. Burke and Edward D. Frank, Boston University School of Medicine's Chester W. Howe, and Tufts University School of Medicine's Louis Weinstein. To begin, here is Dr. Burke in his role as program moderator.
Professor Weinstein will discuss the problems of resistance in bacterial populations.
The problem I want to discuss with you has an important area in surgery, and this is the matter of the increasing difficulties with organisms that are resistant to various antimicrobial agents. And what I want to concentrate on primarily are the new problems in resistance that have developed and come to our attention mostly over the last few years. The two groups of organisms with which you have to deal as much as people in medicine, possibly more, are the Staphylococcus and gram-negative bacilli. And I mean here the common ones, like E. coli, Proteus, Pseudomonas, in that group. First, I'd like to address myself to the problems with the Staphylococcus. As I'm sure you don't have to be reminded, up until relatively recently, staphylococcal infections were the bane of existence of anybody who was practicing medicine. And this all began back around the early 50s, when it became apparent that most of the staphylococci, which in the late 40s had been quite sensitive to benzyl penicillin or to penicillin G, were now becoming increasingly resistant. And this was, in fact, the stimulus for the development of the so-called semi-synthetic penicillins, most of the clinically useful ones being those which resist the action of penicillinase, the enzyme elaborated by the staphylococci which are resistant to penicillin G. And so until very recently, with the availability of a large group now of semi-synthetic penicillinase-resistant compounds, and then the development of a drug like lincomycin, and finally the cephalosporin derivatives like keflin and loridine, I think most of us got very comfortable about our ability to treat successfully staphylococcal disease. Interestingly enough, when the problem with resistance first became really apparent, there was also an increase in the total number of staphylococcal infections around the world, as well as an increasing number of resistant strains, and even more important, types of staphylococcal disease which had virtually disappeared now became prominent again, such disorders as staphylococcal endocarditis, osteomyelitis, and staphylococcal pneumonia. Now, since we have become more successful in treating the penicillin G resistant ones, there's also been a decrease in the incidence of staphylococcal infections, although these two may be associated. I'm not sure that they are, in fact, really related. So we are now in the era, or have been until very recently, of a decreasing problem in terms of incidence, and also decreasing problems in terms of success in therapy, because we now had available drugs that would cure this kind of infection. But I think since I've played with them for a great many years, I'm more and more impressed with the fact that the bacteria are much smarter than the doctors and certainly than the drug manufacturers. So now we're beginning to deal with a new problem in drug resistance among staphylococci. And this is the problem of so-called methicillin resistance. There's an increasing number of reports from around the country that strains of staphylococci that are resistant to methicillin are being isolated from active disease, albeit this kind of infection seems to be less severe than the type that's produced by the methicillin-sensitive strains. Now, were this only a matter of methicillin resistance, it would be a minor problem, because in my opinion, methicillin at the present moment is a drug only of historical interest. It was the first penicillinase-resistant penicillin or semi-synthetic penicillin, and it has been replaced by a fairly large number of drugs which have all of its good properties and lack some of its rather poor ones. But the problem goes far beyond this, because what has been shown is that the methicillin-resistant Staphylococcus is also resistant to all of the other semi-synthetic penicillins, so that oxacillin, cloxacillin, dicloxacillin, nafcillin will also have no effect on the organisms that are resistant to methicillin. Well, then we might take comfort in the fact that even though this group of agents might be no longer available for successful treatment, we could use the cephalosporin derivatives like Keflin or Loridine. Well, it turns out that the bulk of methicillin-resistant strains are also resistant to the cephalosporin derivatives. The incidence of resistance not quite as high. It's 100% for the semisynthetic penicillins. It's of the order of 85 to 90% for cephaloridine and cephalothin, or Keflin. Now, at the moment, this is not a major problem in infections simply because the number of strains of Staphylococci that are resistant to all of these supposedly penicillinase-insensitive antibiotics is still relatively small. But this is very reminiscent of our experiences back in the early 50s or in the late 40s when Mary Barber in London first began to talk about penicillin G-resistant Staphylococci. And as you know, within a very short time, it became clear that we were now dealing with a very difficult problem since we had an increasing incidence of staphylococcal infections and a decreasing capacity to treat this kind of disease successfully because of the high incidence of penicillin-resistant strains. Now, one point about the sensitivity testing that may be of help to you when you run into such organisms that appear at first glance to be sensitive, but the patient fails to respond. And this involves the matter of not allowing the disc sensitivity test to incubate long enough. Since we have become aware of the problem of methicillin resistance, we now ask our bacteriology laboratory to incubate all disc sensitivities for 48 hours. Because what you find now is that the strain may appear to be inhibited in the first 24 hours, but in the next 24, one finds colonies now growing in the clear zone, expressing very nicely the fact that one is dealing with a mixture of methicillin-sensitive but also methicillin-resistant strains. Now, the next area that concerns the surgeon even more these days with respect to the problem of drug resistance is the whole area of infections by gram-negative bacilli. I think it's very clear that nature abhors a vacuum because as the incidence of staphylococcal infections has been decreasing, that space is gradually and rather quickly in some instances being filled by infections due to gram-negative bacilli. There are a number of reasons for this, some of which are quite clear. The fact that you are dealing more often with older people, that surgical procedures are much more extensive, and that patients are getting various antimicrobial agents as well as being exposed either to diseases which are immunosuppressive or they're getting drugs for treatment of their primary disorders which are immunosuppressive. Now, the organisms that we have to deal with that are primarily involved in this matter of the development of resistance are mainly the group of bacteria that inhabit the gut. And so, over the last few years, there's been an increasing experience reported by everybody, not only with a greater incidence of gram-negative bacterial infections, but with a lesser success in terms of their response to treatment when one uses the presently available antimicrobial agents, at least the commonly used ones. And so, we see more and more gram-negative bacillary infections that we can't treat with drugs to which they responded with great ease just a few years ago. The very recent report, for example, pointing out that somewhere between 80 and 90% of all the Shigellas are now practically totally resistant to sulfonamide, a drug which just a few years ago was highly effective against this group. The Salmonellas are showing increasing resistance to a variety of antimicrobial agents. And this all involves operation of one very interesting phenomenon which has been described in detail for us by the microbiologists, and this is so-called episomal transfer of resistance. And what this means in essence is that two bacteria living very happily together in the intestinal tract exchange extra chromosomal material called an episome, which carries on it R genes, the R standing for resistance. And so as a coli and a Pseudomonas lie together in the gut, the coli carries some of these resistant factors on its episome. It now transfers these to the Pseudomonas, and now the Pseudomonas becomes quite resistant to one or more antimicrobial agents. Now again, the problem wouldn't be as difficult if it weren't for the fact that the bacteria are trying to outwit us all the time, so that instead of resistance to one antimicrobial agent developing in this contact in the gut, multiple drug resistance may appear in one contact between a so-called host organism, the one carrying the resistant genes, and the so-called receptor, the one that is now going to become resistant. And as a matter of fact, it's not uncommon in one contact for a sensitive organism to become resistant to streptomycin, sulfonamide, tetracycline, and chloramphenicol, all at the same time. And this may happen, in fact, while the patient is being treated with a specific antimicrobial agent to which that organism was sensitive in the very beginning. Now, there's ample evidence also developing that this list of antibiotics that I just mentioned does not compose the only drugs to which organisms get resistant by this method, because it's now clearly shown that they may also become resistant to kanamycin, to neomycin, and to ampicillin. So that as matters have developed over the last few years, it's become apparent that we are now in the same situation as we were 15 years or so ago with the Staphylococcus. An increasing number of infections produced by gram-negative bacteria, a decreasing capacity to treat them successfully because we're now dealing with a rapidly rising increment of drug resistance, not only to one agent, but to multiple ones. I just want to mention the matter of opportunistic infections. Almost all the journals that one reads today dealing with infections, whether in the medical or the surgical sphere, point out the frequency with which organisms that have in the past been usually considered non-pathogenic are now producing not only infection, but actually severe infection that may terminate in death. And these have been called, I expect for want of a better term, opportunistic infections. What that term really means is infection by organisms that are considered non-pathogenic. And so there's an increasing number of reports of serratia infections. These are the non-pigmented serratia, or what used to be called erythrobacillus prodigiosis, which is producing serious disease and even death, and which presents tremendously difficult problems in chemotherapy because a number of these strains are not sensitive to any of the available antimicrobial agents. The same thing is true of Pseudomonas, enterococcal infections, infections due to such uncommon species as Alcaligenes, many of the fungal infections, not only Candida, the common ones, but some of the higher forms, the true fungi like Aspergillus. And I'd like to look just for a moment at what the mechanisms are that are involved in these opportunistic infections. Well, many of them are the same mechanisms that are operating to explain the increased incidence of gram-negative infections. In essence, poor hosts, patients who have undergone long, difficult surgery, older people, people whose defense mechanisms have been suppressed either because of the disease which they have or because this disease has necessitated the administration of drugs which are immunosuppressive, the corticosteroids, the cytotoxic agents, and all this contributed to, in no small fashion, often by the need to administer antimicrobial agents, which now change the microflora, normally resident in various areas of the body, so that these organisms like Serratia and Pseudomonas and Enterococci and Staph albus now invade and produce disease. One of the very important factors, for example, with which we have had experience in terms of opportunistic infections in surgical patients has been the need for artificial respiration. The application of endotracheal tubes or tracheostomies with positive pressure breathing has not infrequently resulted in the development of Pseudomonas pneumonia, and when we have traced some of these back, we have found that the tubing has been contaminated with Pseudomonas. Finally, with respect to the whole problem of resistance, response to infection, let me just make a few remarks about what I consider to be the important factor in response to treatment when one is able to treat an infection and in response to infection in general. And this is the host. I have been convinced over the years that the host is a much more important determinant of what happens to him when he's infected and when he is treated than is either the organism or the drug which is used to eradicate it. And I think we have learned over the years that with poor hosts, whose defense mechanisms are not just up to coping with the infection, that our results with antimicrobial therapy may be strikingly bad. And what this tells us, in essence, then, is that what happens when one gives a patient an antimicrobial agent is that this drug prepares the organism for eradication by the host. And if you have a patient who cannot mobilize adequate defenses to do this, then he will not control his infection, whether he gets bactericidal or bacteriostatic drugs. I think we see this going on all the time, but don't appreciate it. If this were not true, the administration of any bacteriostatic agent, like chloramphenicol or the tetracycline derivatives, could never produce cure. of infection. All it would do would be to arrest the process, because by definition, bacteriostasis means that the organism is held in check but not killed. But the fact that we cure patients with infections with bacteriostatic drugs, I think, underscores clearly the fact that what is happening is that the effect of the drug is to check the organism, to prepare it, but that the important factor in getting rid of infection is mobilization of adequate defense mechanisms on the part of the host. I think a great many of the problems that we're dealing with today in surgery as well as in medicine, the problems of opportunistic infections, the problems of an increased number of infections due to gram-negative bacilli, all revolve about the fact that we are treating many more poor hosts, and we are sometimes making them worse by necessity because we have to give them cytotoxic agents or corticosteroids which suppress their own defense mechanisms, which may already be poor. And then we add insult to injury by changing their microbial flora when we administer an antibiotic, sometimes for a good purpose and sometimes only in the vain hope that we will protect them against invasion by any or all organisms in their external or internal environment.
The next discussant will be Dr. Frank, who will discuss the problems of gram-negative shock and septicemia.
I think I would ask Dr. Weinstein to include in his list of host factors that provides opportunity for opportunistic infection the category of shock, because that's what I've been dealing with for so many years, and I think if there's anything that's come out of the laboratory in this area and also from the recent years in clinical observations of patients in shock, it is that their resistance to infection is way down, so that they are obviously marks from sources within themselves or without. I have been asked to discuss with you the management of the persisting low-flow state due to infection, also known as septic shock. This pathophysiologic state confronts all of us in civilian practice. The mortality rate is high and is related in part to the pre-shock status of the patient. Thus, pre-existing defects of the major organ systems or of the arterial supply to these organs often provide mechanisms for immediate or delayed death that are triggered by the low-flow state. Factors that are highly related to the opportunity for survival and about which we can do a great deal include immediate recognition and urgent correction of the ever-changing constellation of defects that constitute the shock state. This is best accomplished by the continuous and undistracted attention of the surgeon in charge. He must be willing to defer all other responsibilities in order to offer this one patient a reasonable chance to survive. Now, when I say this to many groups, they say, "Oh my God, how can I do it? I've got so many other things to do." But when you think of your life as a surgeon and mine as a surgeon, we're always willing to drop everything to come to the rescue of somebody who's bleeding massively or who's perforated an intestine or otherwise can't stand by while you get through the office in the afternoon. I think the shock patient should be put by all of us in that same category. I think he does best when he's cared for by you or me if it's one of us who has known him best prior to the onset of shock. The fact that infection is the cause of shock may not be apparent. Fever, leukocytosis, localizing signs are often absent. An abscess, an occluded ureter or bile duct, perforated or necrotic bowel demand urgent surgery. No other measure will permit recovery from shock. The notion that one can treat the shock first and then go to the operating room just doesn't work in most cases. You have to do both together. All possible sources of infection must be considered. Blood, urine, sputum, wounds, peritoneal fluid must be smeared and cultured. Antibiotics and bactericidal dosage should be given intravenously. All drugs in shock in general are given intravenously. And in the presence of peritonitis, intraperitoneally. Initial therapy cannot await cultures, but must be based upon Gram-Sains and good clinical judgment. The synthetic penicillins have been useful initially because of their broad spectrum coverage and low toxicity. For Aerobacter aerogenes, kanamycin is probably the most appropriate antibiotic and can be given to the oliguric or anuric patient as a single initial dose of perhaps half a gram IV, but is not repeated until definitive cultures and sensitivities are available and urine output has resumed. In shock due to infection, we recommend, in addition to appropriate surgery and antibiotic, corticoid in large dosage. Our thoughts on this subject have come from evidences in the laboratory in which circumstance we can save the life of dogs and rabbits that have been given otherwise lethal doses of endotoxin by giving large doses of corticoid. And I, at the bedside, have a feeling that we are helping these people by such therapy in addition to everything else. Point is that this is not a magic weapon. There isn't any magic weapon in shock. Magic weapon is the consortium of all weapons, if you will. One missed defect will be lethal. A little gastric juice in the trachea, a cardiac arrhythmia, a high potassium, an undrained abscess somewhere. Any of these things can kill the patient in shock. No one treatment or missing any one of these defects will, of course, prevent his survival. We've been using dexamethasone, 40 milligrams IV initially, and repeated every 4 to 6 hours. Some prefer to run it in as a continuous drug infusion. This is to combat the lethal action of endotoxin. A favorable physiologic effect is usually observed within 30 to 90 minutes. If discontinued within 48 hours, adrenal suppression does not occur. In the presence of severe arterial hypotension, especially in arteriosclerotic elderly patients, vasopressor therapy is indicated to prevent acute lethal arterial insufficiency of the heart or brain. Here again, there's much knowledge in this field coming in part from our own laboratory output and from many other sources that the vasopressor agents are synergistically bad in relation to bacterial and endotoxins. But I feel strongly that one cannot allow an elderly arteriosclerotic patient to lie in bed being treated gradually for his total configuration of shock-producing defects without taking note of the arterial pressure. Because if his pressure falls below a critical level, which might be 70 or 80 millimeters of mercury systolic, you might be thanked for it by an acute myocardial or an acute cerebral infarct, and the patient's dead. Didn't die of shock per se or per primum, but he's just as dead, and as a clinician that doesn't make you feel very good. This form of therapy is discontinued at the earliest possible moment, that is, as soon as the total therapeutic effort has achieved upward stabilization of the arterial pressure. If the arterial pressure is less than 80 to 90 millimeters of mercury systolic, direct and continuous monitoring via intraarterial catheter, strain gauge, and oscilloscope or permanent recorder at the bedside is desirable. Blood volume deficiency does occur often in shock due to infection. Initial or progressive hypovolemia may not be suspected even by the experienced clinician. This important defect is best identified by repeated direct measurements of blood volume using dilution techniques. The central venous pressure does not correlate in a linear fashion with the blood volume. It is often normal when the blood volume is below normal. Central venous pressures above 10 centimeters warn of an impending pulmonary edema and contraindicate further blood or colloid administration. There does seem to be one group of patients who can tolerate CVPs well above 10 centimeters, and they seem to be the patients who are cardiacs and have had valve replacements or other kinds of cardiac surgery. Somehow they've gotten used to their high CVPs and can tolerate it better than the old man who perforates his sigmoid and develops peritonitis. Ideal control of blood volume replacement is achieved by the combined use of intermittent blood volume measurement and continuous observation of central venous pressure. Recent suggestions that massive injury with or without shock is best treated by large volumes of crystalloid solution make it necessary to warn of the insidious and lethal nature of interstitial pulmonary edema. It is important to know that the central venous pressure is not a useful guide to overhydration with crystalloid solutions. Pulmonary insufficiency occurs in most patients in shock due to infection. Mechanisms include airway obstruction due to retained secretions or aspiration of gastric content, reduced amplitude of respiration due to painful wounds or intestinal distension, pulmonary atelectasis and infection, physical exhaustion. If you stand or sit at the side of a patient in bed and watch him, the only hard work he's doing is breathing. The rest of him is pretty limp and inactive, but after you watch him breathe at anywhere from 25 to 40 per minute for an hour or two, you realize how exhausting that is. If you try it yourself, you'll find out. It takes a lot of work, and it perhaps ought to be relieved in many instances. And pulmonary edema. Pulmonary edema occurring during septic shock, and especially in elderly patients, may be due to hypervolemia, pre-existing or shock-induced myocardial insufficiency, primary or secondary pulmonary infection, or the more recently observed iatrogenic interstitial edema due to excess administration of crystalloid solution. The mysterious wet lung syndrome reported in Vietnam and elsewhere seems to be related to this last mechanism in many instances. Monitoring of arterial gases and pH is essential for optimal control of pulmonary insufficiency. Early, respiratory alkalosis due to hyperventilation is common. Later, if shock persists, metabolic acidosis supervenes. If respiratory assistance is required, every effort should be made to discontinue this form of therapy as soon as possible because of the high incidence of lethal infection secondary to prolonged endotracheal intubation. Myocardial insufficiency, physiologically demonstrated by elevated CVP with a normal blood volume, has been observed in about a third of our patients. Rapid digitalization is useful. The tolerated total dose in most instances is less, perhaps 70 to 85% of that required for patients that are not in shock. Cardiac arrhythmia has been noted in every one of our patients during the course of shock. Continuous monitoring of the cardiogram via chest leads is therefore essential to permit immediate recognition and appropriate therapy. Renal insufficiency is inevitable in shock as part of the definition, and certainly is true in shock due to infection. Mechanisms include renal vasoconstriction, hypovolemia, and renal infection. Hyperkalemia and acidosis may reach lethal proportions within only a few hours. I think that's a point that's not generally understood. We're all used to these phenomena coming on over a period of days in people without kidneys or in people with medical renal insufficiency. In shock, where there is a markedly catabolic effect of massive infection plus tissue anoxia, the combined effects of hyperkalemia and acidosis may be lethal within just a few hours, and you have to watch for it by monitoring the blood chemistries frequently. Early peritoneal dialysis is the best mode of therapy that we know, other than getting the kidneys back in order again. Measures that encourage urine formation include correction of hypovolemia, acidosis, or hyponatremia, control of infection, celiac blockade, which is our form of localized sympathetic adrenergic blockade, and best of all, the control of shock. Mannitol has not been of great value in our experience. We try it, but if you give an ampule and it doesn't work, it's a little bit risky to push it because you'll overexpand the blood volume and face the danger, of course, of pulmonary edema. A wall-mounted flow sheet showing all findings and therapeutic modalities on a common horizontal time axis is a most useful way to keep up with the many changing defects and the treatments in progress. The maintenance of such a chart also provides the bedside physician with a checklist of clinical and physiologic observations and measurements that need to be kept up to the minute until the battle has been won. The best way to treat shock is to prevent it. Early recognition and prompt correction of each defect is far better than last-ditch heroics.
Excuse me, gentlemen, long enough to say that this doctor is the end of this side of your reel. On side B, Dr. Chester Howe discusses obscure sepsis and joins Drs. Weinstein and Frank in answering some questions generated by the earlier discussions. To hear this, simply reverse the two reels or cassette on your tape recorder. Continuing a program devoted to the management of sepsis in the surgical patient, this is Audio Digest Surgery, Volume 16, Number 8, Side B. Once again, our program moderator, Dr. John F. Burke.
The next discussion will be given by Dr. Howe, who will talk about obscure sepsis.
I'd like to discuss particularly one type of obscure sepsis, of which there are many. By that I don't mean that there's any question in the given case whether or not infection exists, but rather where it exists. It may be an abscess that's obviously localized, that can't be found, and in some cases proper treatment with antibiotics and drainage has already been carried out, and yet the signs and symptoms of infection still persist. Now, in a great many of the cases that have been referred for this reason, I'm sure that in the mind of the referring physician, the thought was that perhaps I had some new antibiotic that wasn't released yet that would cure the infection. And of course, this is not the case and is not the problem. These patients usually have had a full gamut of antibiotics, and some of them have had several attempts at previous drainage. Since Dr. McCabe has been at our hospital in the last few years as Chief of Infectious Diseases, I don't get as many of this sort of drug question referrals. He gets them. And once in a while he'll come to me wringing his hands and say, "Can you help me persuade this surgeon to drain this abscess which I know is there, but we can't find it?" This is the type of a case I'm referring to. And of course what you need to know is the central focus of that infection, why it stays alive, what keeps it going despite what seems to be adequate therapy, and then the proper diagnostic steps to take to find out about it, and lastly, the proper treatment. Now, a very simple example of this is not infrequently I'm called to the ward by one of the house staff to see a patient that's had a diagnosis made of an abscess. An incision has been made for drainage, and more than likely it's an adequate incision dependent and all that. But when you remove the dressing, you see a great big pack in the wound. The pack is holding the wound spread apart, so that if you left it there 5 or 6 days, that wound would fix in that position and would take much longer to heal. But the important thing is that this pack is converting the wound and the patient back to the same status that he was essentially before the drainage, because it's closing off the opening he made, and there's a nice little warm cavity in there for the bacteria to grow in and to hold in the products. Moreover, the serum seeps into the pack, the bacteria follow the serum and grow in the pack where they're not affected by whatever host defenses there may be. Of course, the solution to this is simply to remove the pack. But in the more complicated type of a case that comes with this problem, one of the first things that I do is to omit all antibiotics. Now, this is not a dangerous thing to do. The patient has usually been on antibiotics and not responding, and if you have them in the hospital where you can observe them daily and start the antibiotic again if he has a flare-up, there's no danger to this, in my opinion. At least I've never got in trouble doing it. The reason for omitting the antibiotics is not that I think it's going to be a drug fever, although over the years there have been several cases that have turned out to be, and that was all that was necessary. But the reason for omitting all the antibiotics is because I know that in 5 to 15 days that patient will tell me where the infection is by developing a tumor or a palpable mass or an area of reddening or edema or some tenderness, which will allow me to put in a needle, get some pus, and then go at it surgically and do the proper drainage or debridement under cover of proper antibiotics. Now, many of these difficulties could be eliminated with a more thorough understanding of the difference between invasive infection and chronic suppurative infection, which are the two main types of surgical sepsis, and their therapeutic implications of each of these types of infections, together with a more basic knowledge of process of wound healing and inflammation. Now, fundamentally, invasive infection implies that virulent organisms are growing and progressively involving new healthy tissue without localization, which may come later. The cellulitis type of a thing. Now, the function of antibiotics in invasive infection of this type is curative, and if you give the right antibiotic early enough, you can cure the disease. But once chronic suppurative disease is present, once there's localization, and the postoperative wound infection comes under this category after the first few days, once there's suppurative disease with an abscess wall and pus and necrotic tissue, antibiotics don't work. They don't cure the abscess. They don't cure the disease. But the trouble is, the crux of the matter is that these two types of surgical infection exist concurrently in the same patient. For example, you'll see a wound infection with pus, may or may not be adequately drained, but around it there'll be a zone of red cellulitis, edema, redness, tenderness, and the patient has a fever. So the doctor gives an antibiotic, and the redness goes away, and the edema subsides, and the tenderness disappears, and the fever comes down, but not all the way. It comes down to about 100 or 101, and it spikes every day. And so the doctor raises the dose. Well, nothing happens. And if he's a good one, he'll take another culture, and lo and behold, he'll find that there are some different organisms in the flora than there were at first. In fact, they may all be different. So he gives a new antibiotic on the basis of the new flora, and another good response comes, which encourages both the physician and the patient, but the same process happens some improvement, but the thing keeps smoldering on. And so this process of changing drugs, increasing the dose, and a new superinfection each time can go on ad infinitum until the patient ends up with a chronic infection with a Pseudomonas or a Manila that's very difficult to treat. Now, abscesses, such as subdiaphragmatic abscesses, over the past 20 years, at least for me, have been more difficult to find because of the masking effect of antibiotics. You have to go in deeper. They're smaller. You're not led to them as easily by the massive surrounding induration that used to exist. And when you find it, it may be just a little shallow cavity with a little exudate and a few curds in it. This masking effect is one of the reasons for obscurity of an abscess, and some of them have had several attempts at drainage. And these cases sometimes end up with a chronic draining fistula. Now, the main causes of chronic draining fistula are communication with a hollow viscus, a neoplasm, granulomatous disease, foreign body, and an undrained or improperly drained abscess. Now, when you get one of these, the common practice is to put a catheter in the sinus and inject some radio-opaque material in and watch it under the fluoroscope and take pictures. But the trouble is that you can't put it in under pressure. Now, I think this is an important point, that you've got to be able to put it under a little pressure. And also, it runs back out around the catheter and gets on the skin and it obscures the picture. If you're lucky and have a small sinus, you can put a Foley in, blow up the balloon, get a watertight connection, and then you can put it under a little pressure. And if not, I think it's worthwhile in these seriously debilitated cases that have had several attempts to take them to the OR the day before, if you can, and raise up a little cuff or circle of skin around the sinus and fold it up around the catheter and purse string it in to get a watertight connection. And then you can put on a little pressure. There's been a recent report by Sherman and his group from Ohio State, in which they discuss 130 subphrenic abscesses, and of these, 17 of them had 2 abscesses. So this is one cause of obscurity. If you drain one, you think you've got it all, and you haven't, and you have to go back. And another series of cases recently reported, 17% had to have more than one attempt before all the abscesses were discovered.
Some questions to the panel. Louis, the problems of treating an acute infection in a very sick patient, I think, are ever before us, and it's a little bit difficult sometimes to wait until the bacteriologic lab tells us the shoe size and the barracks bag number of the particular bacteria so that we can go to the pharmacy and find the exact antibiotic. If you had a patient who you thought ought to be treated immediately and you were on clinical grounds sure that this was a staphylococcal infection, what antibiotic would you use and what reasoning would you base this?
Well, if there were a staphylococcal infection, first one could reason on the basis of where it occurred. If it occurred outside the hospital, there's only about a 5 to 10% chance that one would be dealing with a penicillin-resistant one. On the other hand, if the staphylococcal infection developed in the hospital, then the chance is about 95% that it is penicillin-resistant. On the other hand, because the patient you described is so sick with staphylococcal infection, we would not tempt fate by using plain penicillin G. We would go immediately either to a semi-synthetic penicillin, oxacillin, cloxacillin, nafcillin, and give large doses. We frequently give 8 grams a day of oxacillin until the situation defines itself, or go to one of the cephalosporin derivatives, and it's with these that, frankly, I've had more experience than even with the semi-synthetic compounds. But the problem here, I think, is that many people tend to undertreat with the cephalosporins, so that when we use Keflin or cephalothin, our usual dose for severe infection is 12 grams a day, 1 gram intravenously every 2 hours, dissolved in 20 to 30 milliliters of saline and run in over about 20 minutes so that we get repeated spikes every 2 hours. If you use cephaloridine, the Food and Drug Administration limits us to 4 grams a day, and one dare not exceed this dose because if you do it in 2 patients, you have to get a new drug investigation form filed. So 4 grams is the total of cephaloridine that can be given. We have given as much as 24 grams a day of Keflin without any trouble except for anemia, and this is readily reversible when one stops the drug.
Is there any situation where you think you ought to give penicillin G and a semi-synthetic penicillin?
Not for gram-positive bacterial infections, no. I think the old use of methicillin together with oxacillin, or staphylococcus with prostaphyllin, I guess are the trade names, was because it was well known that methicillin was not as effective for penicillin G sensitive organisms as penicillin G itself. So in order to cover that possibility, the two were given together. Now, we have attempted, in company with a number of other people, to treat Pseudomonas infections with a combination of penicillin and a semi-synthetic penicillinase-resistant penicillin. We have been successful in some cases, not very successful in others. And I think there's a lot more to the management of Pseudomonas infection that may spell doom for the patient than the kind of antibiotic he gets. Pathological, the morbid anatomy of Pseudomonas infections, particularly in the lungs, which are the ones that we have to deal with most often, is such that it makes it extremely difficult to control these, no matter how effective is the antimicrobial agent.
Could I ask Dr. Weinstein whether he thinks there's any indication at any time for prophylactic chemotherapy?
When one thinks of chemoprophylaxis, you're thinking of small doses of drug that will prevent the implantation of organisms. And so I think what the surgeons are now trying to do, at least it seems to be very successful, is to protect the suture lines against invasion by bacteria, which means a burst of chemotherapy over an 18 to 24, maybe 36-hour period, and that's all you need. Now, there's very good reason for doing this, because when one looks at the factors that influence the pathogenesis superinfection, probably in addition to the broad-spectrum drugs, the most important one is the duration of prophylaxis. And if you stay within 48 hours, the risk of superinfection is very low. And I would go along completely with this kind of approach because that's prophylaxis. But if you give somebody 20 million units of penicillin a day and 2 grams of streptomycin, a little sprinkle of chloramphenicol, and a sip of tetracycline, that is not chemoprophylaxis, that's lousy treatment, to put it crudely. Now, in the elective surgery, Dr. Frank, I can see no indication. I have worked out for myself, I don't know whether this is useful for anyone else, 2 very simple rules for chemoprophylaxis. And these are as follows. If the purpose of the prophylaxis is to prevent implantation by a single organism, and a single effective drug is given, and I refer to such things as streptococcal disease, gonorrhea, etc., then the chances of prophylaxis being successful approach 100%. If the purpose of the prophylaxis is to prevent invasion by every organism that exists in the patient's outside and inside environment, then the chances of failure are almost 100%. Now, this is not a statement I base purely on an emotional reaction to chemoprophylaxis. I have been studying this problem now for some 20 years. And this is not only impression, but we have data to support these remarks that I've made. I think a great deal of trouble has been created by chemoprophylaxis that could be well avoided. Furthermore, if one is operating in an area that's already infected, as Dr. Howe has pointed out, if, for example, the urological surgeon asks us about, quote, chemoprophylaxis in a patient who has a renal carbuncle or is being operated on because of obstructive problems in chronic pyelo, we certainly urge the urologist to give an antimicrobial agent, but not prophylactically. He treats the infection, operates, and then continues to treat. This is very far from prophylaxis. I think one must also keep in mind one point that I just must make, and that is that in this wholesale chemoprophylaxis, in the hope of preventing infection, which we may accomplish on occasion, I think by accident, we lose sight of the fact that there is no antimicrobial agent which is without trouble. And I have learned over the years that there's been a whole area of new medical problems that have been created by the use of the antimicrobial agents. And there are many people who suffer not because of their disease, but because of their treatment. And I think once one gets this well established in mind, then his approach to chemoprophylaxis and even to chemotherapy is much more sound, and what is most important, much more safe.
Dr. Frank, I noticed in your discussion of the various drugs that you like to give during septic shock that isoprel was absent. Does this mean that you don't like isoprel?
No, but it just means that I think it has a limited application. McNeil, as you know, in Montreal, has been using isoprel a good deal in his patients in shock. The idea is, of course, to create a better muscular activity of the heart, increase cardiac output. One has to be very careful about isoprel, of course, because of its tendency to increase heart rate. If you're dealing with a patient in shock whose rate is already 120 or more, and I think isoprel or isoproterenol is contraindicated, because if you push it much faster, first of all, the cardiac output will go down instead of up, And secondly, of course, you can develop serious arrhythmias. But I think it is a drug that has useful applications, but you have to know its limitations.
Dr. Frank, on manipulators of the peripheral resistance, what are your indications for the use of dibenzoline?
Dibenzoline is an adrenergic blocking agent which has been suggested for the restoration of flow to those areas that the body has chosen in its wisdom to relieve of flow during the shock state. Namely, the body in its response to shock of many sorts, or most sorts, will vasoconstrict. The areas of vasoconstriction are sometimes injured to a point. Interestingly enough, some of these areas are the splanchnic areas in which the defense mechanisms exist, antibacterial defense mechanisms, the gut, the liver, the spleen. If this goes on long enough, then in line with this total discussion today, the host becomes weakened and his ability to tolerate or to destroy bacterial toxins as well as bacteria themselves, and therefore the notion has developed that it is useful to help the patient by opening up these constricted areas. We would go along with that. The warning about it is that if one reduces the peripheral resistance diffusely with a drug such as dibenzoline, that one must face the inevitable physiologic fact of hypotension. In other words, as the peripheral resistance falls, the blood pressure will fall with it unless you do something else. And those who use these drugs, I'm sure there will be strong warnings about hypotension because, as I said in my talk, this leads to marked critical reduction of flow to the coronaries and cerebral circulation and may be lethal. One must do something to sustain pressure for that reason and during that period. And those who use the drug or drugs like it will insist upon overfilling the blood volume capacity. In other words, by giving transfusions of blood or plasma or colloid to make sure that the arterial pressure is sustained at the same time. We have felt that this has its hazards in regard to the lung. If you overfill the circulation, one must watch out for what happens very commonly in old people, especially in septic shock or infections or massive trauma. Their lungs are very vulnerable, and if the blood volume is overexpanded just a wee bit, they don't take it, and they'll go into pulmonary edema or have a larger opportunity for developing a lethal pulmonary infection.
These are the physiologic parameters, but when you're sitting on the firing line and you're standing before grandmother's bed, what clinical signs and symptoms make you decide I will or I will not give dibenzoline in this case of septic shock?
We think we can deal with most situations, all of them, without dibenzoline. That doesn't mean that we don't respect the work of those who use this drug. Those who use it with the knowledge of the hazards, and they know how to replace volume at the same time as they are reducing peripheral resistance. We have been basing our effort to achieve adrenergic blockade on some of our laboratory efforts, which indicate that one of the target areas, again, the splanchnic area, can be protected by doing localized adrenergic blockade of the splanchnic area. This can be done with a retroperitoneal introduction of a long-acting local anesthetic, such as 1/4% xylocaine, 40 cc's, just as you would for a paravertebral block. This can be done with old grandmother lying in her own bed without moving her anywhere.
Okay. What are the things that you want to see before you'll do this? What are the things that make you stick that needle into her?
We would first of all resuscitate. I think the first thing to do is to make sure the airway is adequate, that there is no gastric juice in the pharynx, that the patient is ventilating with or without your help. If the patient is not ventilating without help, she must have help acutely. This may be an endotracheal tube, in spite of everything we've all been saying about those tubes. For the acute moment, you must make sure that the blood is being oxygenated. We would then assure the patient an adequate arterial blood pressure, and as I've said, we do this urgently with small doses or whatever doses we need of a vasopressor agent until we can make other restitutions. Now, those other restitutions then come on very quickly by way of correcting blood volume deficits if we have reason to believe that they exist, by way of operations if we think that there is a perforated bowel or an undrained abscess or a source of infection that needs surgical attention, and so on. In other words, the whole gamut of efforts is quickly brought to bear as soon as the resuscitative initial adequate airway and arterial pressure has been stabilized. I think if you don't do those two things first, you don't have much of a patient to work with. Now, after you've done that, and if the patient is still anuric, and incidentally a paravertebral block, if you will, of the sort I've described, in about 50% of cases will help In other words, in 50% of the cases, we have seen an increase in urine flow or an initiation of urine formation, and we do put catheters in all of our patients in spite of the hazards of urinary catheters, because we feel that in shock, we must know something about urinary formation as one of the important areas of our concern. So that the paravertebral block or the celiac blockade can be useful there. There again, one can get a transient fall in blood pressure due to the fact that one has lowered resistance in that area, but it's not as devastating as that which occurs with dibenzoline. And I might say that in the past year or so, we have been leaning heavily on this drug that I'm sure others have important negatives to say about, namely the corticoids. Corticoids have physiologically an adrenergic blocking effect as well, at least as we study cardiac outputs and make our determinations of total peripheral resistance. In many cases, a massive dose of corticoid will result in calculations indicating reduction in peripheral resistance and also increase, in many instances, in urine formation. The corticoids we have used because we feel that in many cases, old grandmother or any other with massive septic shock, it would be nice to get rid of the endotoxin. It's one thing to kill off all the bacteria, but if the patient's left with a, quote, lethal dose of endotoxin on board, then of course the patient will die by definition. What can one do to reduce the lethality of pre-existing endotoxin, even assuming that one can do proper surgery and offer proper antibiotics? What can you do to get rid of the endotoxin on board already, or at least mitigate its effect? And this, again, is where we feel that corticoid has a part to play, if the other measures are also taken.
Dr. Howe, in the old days, obscure sepsis used to be treated by pulling all the teeth, and that isn't popular anymore, so we've got a pretty difficult problem. Can you give us any ground rules on where the likely spots are so that we can start to look at some reasonable place rather than examining the whole corpse millimeter by millimeter?
Well, in the field of abscesses, it can be most anywhere, but the difficult ones, the problems that are hard to solve, are usually in the abdomen or in the thoracic cavity. It can be anywhere in the abdomen. They're obscure because they're bizarre. They don't happen very often, but...
Chester, could I contribute one for you? One I think that's very important for everyone that deals with hospital patients, which we're all living with. That's the only place we function. Watch out for those catheters. The catheter in the arm that's in there, that's saving life, is also causing death. And I say it to you not only because you don't already know that a red hot streak up an arm is bad news, but I say it to you in further terms by indicating that we have now several instances in which there is no local reaction whatsoever. The catheter looks just beautiful in there. There's no redness, no edema, no tenderness even. The patient is being supported by that system, and you pull the catheter out, and you find a Staph aureus or some other bug growing right on the tip. There might be a little clot at the tip that's nurturing it along, but that's one thing that I always do, in addition to the whole checklist of other things that everyone does to look for obscure infections, is to pull the catheter and change it if it's needed, or do without it if you can.
Oh, I agree with that. I was talking about abscesses. One of the first things I do if I'm called to see a case of obscure sepsis or fever of unknown origin, if that patient has got a catheter in, I'm talking about a plastic polyethylene or polyvinyl intravenous catheter, is to take it out if at all possible. There's a very high incidence of sepsis following these. There's a study done by Bentley and Lepper in Chicago recently, and they showed that 19 out of 44 hospital-acquired septicemias, which is 43%, I believe, were caused from catheters, intracasts, that had been in over 48 hours. Dr. Frank said 24. Well, it's better to take them out earlier. I don't think you should put them in at all unless you have to, and it's surprising what you can do with ordinary old-fashioned intravenous work if you keep the doctors away from the patient and let the intravenous nurse do it, because they're pretty skillful. And since the advent of intravenous nurses, the doctors have more or less lost their skill. Now, if you have to have a catheter in for central venous pressures or something else, I think it should be moved every 48 hours or alternated with needle work.
I have some experiences with the abscesses that Dr. Howe has talked about, because we admit to an infectious disease service a lot of patients with fevers of unknown origin. As a matter of fact, this is the bane of my diagnostic existence. And the first place we look, Dr. Howe, if we suspect that there may be an intra-abdominal lesion, is the liver. We follow the scan usually with arteriography, because we're never quite sure in the smaller lesions whether we're not dealing with some vascular deformity in the liver rather than just a hole. Surprisingly, These may be amoebic abscesses which have sat there for a great many years and caused no trouble
Find
until...
most of them in the right lobe?
Not all of them. Most of the
About
amoebic
80%?
abscesses are in the posterior portion of the right lobe, but we've also had them in the left lobe and in the anterior portion of the right lobe. So the old saw about if it's in the posterior portion of the right lobe, it's amoebic, doesn't hold, because we found real suppuration also in the posterior portion of the right lobe of the liver. Well, I think that's the first place to go. Again, because of my experience with fevers of unknown origin, I've been impressed by the fact that any disorder of the liver, ranging from infection to acute fatty changes associated with alcoholism to tumors to whatever you name it, may well be associated with fever. That organ somehow, regardless of its type of involvement, produces fever.
Thank you, gentlemen. And this concludes this edition of Audio Digest Surgery, produced twice each month by the Audio Digest Foundation as a nonprofit subsidiary of the California Medical Association. All rights are reserved.